So we have started the webinar. We just got into the first few poll questions, as you might have noticed. And now we have our first open-ended question for you. And that's where we want to know, what are you hoping to get out of the webinar today? So if you could just use the, put your response in the questions box on the right-hand side of your screen, that would be fantastic. All right, and thanks everyone for your responses. So it looks like someone says that they're looking for ideas for direct care staff training. Someone wants some more ideas for knowledge on maintaining and improving mobility, and as well a couple other people are just looking for any new ideas on this topic. So thanks for letting us know.
All right, great. So we're going to jump into our webinar then. So the objectives for today are we're going to discuss current evidence for strategies to maintain and improve resident mobility. And then I'm going to present some practical solutions for putting that evidence into practice in long-term care homes and examine ways to modify suggestions that I'm going to make for different physical and cognitive abilities. So just a little bit about long-term care. I know most of you are practicing in long-term care, so this might not be new information for you, but there are many long-term care homes in Ontario, 625 to be exact. Most have long-stay beds, or most beds are long-stay, and then there's a small number of convalescent care beds and an even smaller number of respite beds. There's about 7.1% of older adults over the age of 65 who live in specialized care facilities like long-term care. And the Ontario government has plans to add about 5,000 more long-term care beds over the next 4 years if they get re-elected. But the point being that there are lots of long-term care homes, and this is a sector that's going to continue to grow. So residents in long-term care often have complex issues going on. So they have lots of different comorbidities, often not just one disease process going on, but several. Physical impairments, cognitive impairments, and activity limitations, which is usually the reason why they're there. So physical impairments, there's a high prevalence of sarcopenia, so that's age-related muscle loss. And a lot of times this leads to activity limitations. As well, a lot of residents do have cognitive impairments. So more than 80% have some degree of cognitive impairment, while about 56% have a diagnosis of Alzheimer's or other dementias. So this is something that we really need to consider when we are prescribing exercise or physical activity and to help residents maintain and improve their mobility. For activity limitations, most residents require some assistance with their activities of daily living. And a lot, more than 80%, require extensive care. And what is a big target for me, and something I think we can all really work on, is one study found that on average, residents spend 3/4 of their waking time in sedentary activities. So they're spending lots of time, sitting, lying down, and not being as active as they could be. All right, so I have another open-ended question for you. So I want to know, if you're working in a long-term care home, what do you currently do in your home to help residents maintain or improve their mobility? Or if you are a resident or a family member, what do you do to maintain or improve your mobility?
All right, and again, we'll give everybody about a minute to think about your response to this question and type it in the questions box on the right-hand side of your screen. All right, and so what we're hearing from you all regarding this question is, regarding range of motion, some strength and balance exercises, doing things like walking, upper arm and leg pulleys, or exercise classes, chair, Zumba. That's a really good idea. Someone else is saying that they do a daily exercise program on each of their unit or home areas. Activation runs the program and works on ROM to maintain strength. Do you know what ROM stands for, Caitlin?
Range of motion.
Range of motion. There we go. Learn something new every day. Yeah, and as well, there's a couple other views saying that they have a physio program as well as a restorative nursing program, and that you try to get people involved with it. So thanks for letting us know.
Great. So I want you to keep in mind what you currently do, and as we go through the presentation, are there any modifications you can make to what you currently do, or is there something you want to add based on what I'm going to talk about today. So there's this really great paper. I just took a screenshot of it so that you can find it. It was published in JAMDA in 2016, and basically it was a task force report where they looked at all the evidence, all the systematic reviews that have been done, and tried to bring it all together and make some concrete recommendations for physical activity and exercise for older adults living in long-term care. So we're going to go through some of the recommendations that they had because I thought they were really interesting. So this is one of their kind of key tables, and it's a summary of everything that they say in the paper. So on the left-hand side, they have suggestions for increasing overall activity levels in daily life. So this is just getting people being more active throughout the day. And then on the right-hand side, they have recommendations for exercise training. So this is, specific exercise programs where you have a set time of the day that you're going to do exercise and it's purposeful, rather than on the left, it's just kind of getting people moving around more. And on the right, I just want to draw your attention to the fact that it's for residents who are capable of ambulating or rising from a chair. And if you read the little star at the bottom, it's rising from a chair and ambulating with or without human assistance. So I recognize it doesn't include people who aren't able to walk, but we'll talk about that a little bit later. All right, so we're going to start, we'll just focus in on the left-hand side first, so just overall getting people moving more. And I've highlighted some key things that I think are important. So one thing was encouraging long-term care staff to adopt strategies to break up sedentary activity. So as I mentioned, we spend a lot of time sitting, lying down in long-term care. So is there ways to just intersperse activity, even if it's 2 to 5 minutes at a time, and we do that 2 or 3 times a day. So maybe it's putting in a little walk, instead of just sitting and watching TV, maybe when there's a commercial on, standing up a couple times, sitting back down, walking to the dining room rather than being pushed in a wheelchair if they're able to walk. And that really focuses on the next item, number 3, so stimulating residents to move. So, if they are able to walk, helping them to walk to the dining room, helping them to walk to the common room, rather than going in a wheelchair, of course, when possible. Number 4 is organizing group activities that are motivating and pleasant, just to get people out and about, out of their rooms more often. So things like going to look at the garden, dancing, walking in green spaces, those types of things. And then the last one is using innovative solutions that help people be more active. So things like animal interventions, new technologies. So I know a lot of homes have, dogs come in and visit, maybe walking beside the dog rather than just sitting and petting it. Or there's new technologies, so things like Connect games or Wii games if people are interested in that. All right, so we're going to move on to the more structured exercise component. Now, I really like their first suggestion, and that's why I highlighted it in green. If I was a bit more tech savvy, I would have put like flashing lights around it or something, but I think it's really important. So every resident who has no contraindications to exercise must have a personalized exercise program or as part of his or her health care plan. So I think that's really important. There is no reason why people shouldn't have an exercise program as part of their plan. And of course, it should be individualized. So it should be relevant to the person, something that they like to do, and incorporated into their healthcare plan. So in terms of exercise type, the best exercise for long-term care is multi-component training, specifically incorporating muscular strength, cardiorespiratory endurance, flexibility, and balance. But really what's important is strength. So I mentioned before that sarcopenia is very prevalent, and that's age-related muscle loss. And muscle strengthening exercises can help sarcopenia and help prevent kind of the things that result because of sarcopenia, so things like falls or decreased mobility, inability to perform activities of daily living. So strength training is very important, and then also those other types as well. And we'll get into some more specifics shortly. In terms of exercise intensity, it should be a moderate intensity. And this is, I think, where we often don't challenge people enough. So moderate intensity. So for strength, that means they should be doing 1 or 2 sets of exercises performed at about 13 to 15 repetitions. Sometimes you see even lower numbers, like 6 to 8. But the point is, by their last repetitions, somewhere between 8 and 15 repetitions, they should feel like they've done something. They should feel like they're tired, like they've worked. If they can do 15 repetitions of an exercise, no problem, and they could keep going for another 15, then it's probably not hard enough. It's not at a moderate intensity. It's not going to change anything. For aerobic exercise, the moderate intensity is scoring about a 5 or a 6 on a 10-point scale. So if 0 is nothing, you're sitting in a chair watching TV, and 10 is all-out perceived effort. So you're working as hard as you possibly can. A moderate intensity is about a 5 or a 6. Another general guideline you can use is if you were walking beside somebody and you were talking to them, you'd still be able to talk to them at a moderate intensity, but you wouldn't be able to sing a song. Not that anyone wants to hear me sing anyways, but that's just one other way you can think about it. And then their last point is that high-intensity exercises can be executed, so it's not that they're unsafe, but they may require closer monitoring. So they could be a bit more high risk, especially for a high-risk population. So that's where you should really get some advice from exercise professionals. In terms of the frequency, they suggest twice a week with an interval of about 48 hours or 2 days between sessions. And if residents are fitter, they could certainly do a higher weekly frequency. And they recommend a duration of about 35 to 45 minutes per session. But if someone's really deconditioned, they haven't exercised before, certainly you could start smaller and then build up to that 35 to 45 minutes per session. So this is a really good paper just to kind of give you some nice concrete recommendations. So next, I'm just going to go through the evidence for a couple of different things. So first, exercise to improve activities of daily living. So activities of daily living are things that the resident does every day, or that we all do every day. And these are basic activities of daily living. So things like going to the washroom, showering, washing your hair, eating, feeding yourself, getting dressed and walking, and also transferring between surfaces. So getting in and out of bed, getting on and off the toilet, getting in and out of a chair. So what has been found in the literature is that exercise can have a small positive effect on activities of daily living when it's delivered for about 45 to 75 minutes per session, 2 to 3 times a week. So that's very similar to what I just mentioned from the previous paper. So next, I'm just going to talk about the evidence around exercise to prevent falls. And we know that falls can have really, dire consequences in long-term care and in the community, leading to decreased mobility, pain, and even death. So it's important that we find ways to prevent it. And so I wanted to talk about the role of exercise in terms of preventing falls. So there's been a couple systematic reviews. The first one was done in 2012, and systematic reviews where they bring together all the literature about this topic and try to make some conclusions about it. So the first one in 2012, what they concluded is that the evidence surrounding exercise, just exercise by itself, to prevent falls in long-term care was inconsistent and did not demonstrate an overall benefit. If residents were frailer, exercise programs might actually increase the risk of falling, but if they're less frail, it might decrease the risk of falling. So there's some suggestions that we might need to target exercise and make sure that if a resident is frail or at high risk for certain events like falls or fractures, that we might need to target our exercise a bit more and also include other interventions, so not just exercise. And they found that interventions targeting multiple risk factors might be effective. So things like specifically targeting gait, balance, and functional training. So functional training being practicing activities that you would do in your daily life. So things like getting in and out of a chair, getting in and out of bed, those types of things. So there was another systematic review that was done in 2013, and they found very similar things whereby a combined exercise program that includes balance tasks specifically, so combined being they don't just do balance, they do balance and strength, they do balance and cardiorespiratory exercise, were completed frequently. So again, there's that 2 to 3 times per week. And they added that over a long term, so greater than 6 months, were most effective at preventing falls. So similar recommendations, they added in the longer term, the 6 months. All right, I think I skipped a slide. Yes, I did. Okay, so in 2015, there was an umbrella review, and that's where they kind of look at all the systematic reviews. And they made the same conclusions that really multifactorial interventions were the most effective at preventing falls in long-term care. So doing more than just exercise, including other components into the falls prevention program. In 2015, recommendations were developed for fracture prevention. And this kind of goes back to what I was saying before about targeting the exercise. So they concluded that balance, strength, and functional training should be included for residents who are not at high risk of fracture. But if they are at high risk, exercise should be provided more as a multifactorial falls prevention program. So it shouldn't just be exercise by itself, it should be exercise in conjunction with other things. And then in 2016, there was a systematic review, and this is in line with what I've been saying. So exercise just by itself, only exercise, there is no evidence that exercise just alone could prevent falls for residents in long-term care. So really it needs to be a multifactorial approach. And I'll talk more about what the other components of that could be later. So there is a really exciting study that was just published actually at the beginning of February in JAMDA as well. So that's why I put the most recent evidence for exercise to prevent falls. And it was a study done in Australia where they looked at progressive resistance and balance training for falls prevention. So I'd suggest you look this one up. It's a really good study, really interesting. So this is what their exercise intervention looks like. And they compared those who exercised with those who didn't. So in their exercise group, they did individually prescribed progressive resistance training and balance training. They did it in a group setting, and their ratios were 5 to 1. So they had 5 residents to 1 exercise instructor who was leading the group. It was done 2 times a week, just like the recommendations that I presented before. They had a little bit longer sessions, so they were about an hour. And they did this study for 25 weeks, so that's about 6 months if you do the math. And then after the 6 months, they did a maintenance program for 6 months. And in the maintenance program, they didn't do progressive resistance training, so they didn't make it any harder. They just kind of continued doing what they were doing for 6 months. So what they found was that there was decreased falls and fall rate in the exercise group compared to the group that didn't exercise. They had a similar number of fall-related fractures. So a lot of times falls can lead to hip fractures or wrist fractures. And they found that they were about the same between the 2 groups. And what I thought was really interesting is they looked at if people attended the group exercise or not, or if they attended it kind of sporadically, and what was that kind of number where they actually saw improvements in falls outcomes. And they found that participants who attended more than 30 hours of training saw improvements in fall outcomes. So that would be, you know, they have to go twice a week for about 15 weeks to actually see improvements in falls outcomes. And I think this is really important, you know, that it's, what I want to emphasize is that it's progressive resistance training, so they're making it harder as they go along, rather than just doing the same exercise over and over. 2 times a week for 1 hour and for a long period of time. So sometimes I think it's a challenge to implement these things in the real world, but I think it's important that we know that to actually see a difference, they have to be challenging, they have to be delivered for a long time and fairly frequently throughout the week. So in terms of the multifactorial programs that I was talking about, these are just some examples of what else besides exercise has been studied in the literature and shown to prevent falls. So staff and resident education, environmental modifications, supply or repair or provision of assisted devices, so things like walkers and canes, falls problem-solving conferences. So I know a lot of homes, what they'll do is right after somebody falls, they'll have a little huddle and talk about this, you know, why did that person fall? What can we do next time to prevent it? You know, what are the contributing factors that we could work on? And those have been studied in literature and shown to be helpful. Urinary incontinence management, and then also medication reviews. So making sure they're not on medications that could be contributing to their falls, or if they are, there's a strategy to help prevent the fall. All right, so enough of me talking. It's time for you to tell me another thing. So we're going to talk about strength exercises in a moment. And I want to know, what's your favorite strength exercise? So either to do with a resident, or if you are a resident, to do yourself, or if you like to exercise, what's your favorite strength exercise to do?
All right, thanks, Caitlin. And again, everyone, just take a few seconds to think of what your favorite strength exercise is and type in your response in the questions box on the right-hand side of your screen. All right, so we're hearing from you that people like using weights. Yep, that weight exercises seems to be pretty popular. Someone else is saying with the resident with the new step machine. Do you know what that is, Caitlin?
Yeah.
For those of us that don't know?
Yeah, so it's like a seated stepping kind of machine. Yeah. All right, great. So we'll move on to talking about some strength exercises. So strength exercises are where the resident is working against resistance. So the resistance can be in a couple forms. So it could be external resistance, like a dumbbell, or a TheraBand, or a weight machine. Or it could be the resident's own body weight moving against gravity. So something like a squat, a wall push-up, anything where they're moving their own body weight against gravity. So to change muscular strength, exercises need to be a couple things. They need to be challenging. So as I was describing before, 1 to 2 sets of 6 to 8 or 13 to 15, depending on which source you look at, before the resident is fatigued. So definitely those last few repetitions should be hard, and they should be feeling tired by the end. Residents, if they're particularly deconditioned, so if they haven't exercised in a really long time or they haven't exercised before, they might need to begin with a lower intensity just to get the exercise down and make sure they're doing it with proper form, and then progressively make it harder. So for example, they could start with 1 set instead of 2, starting with a lower resistance, so less weight that they're holding, or with an easier version of the exercise. And then the other thing to change muscular strength is exercises need to be progressive. So they need to progress over time. So if they're doing the same exercise for 3 months, that's not going to help them change their strength. So progression could be a couple things. So you could increase the number of sets. So doing 2 sets instead of 1, doing 3 sets instead of 2. Increase the resistance. So holding dumbbells while squatting is one example. So if they can do a squat or a sit to stand, no problem. 15 repetitions is a breeze. Then you could add some weight so that they're holding a dumbbell while they're doing it. Or the intensity of the exercise. So for example, if we talk about the squats, squatting lower or faster. So for example, it's easier to stand up out of a chair that's higher, has a higher seat, than a chair that's really low. So maybe you start with a sit-to-stand exercise, which is kind of similar to a squat, from a high chair that has a high seat, and then as that gets easier, you go to a lower and lower chair. Or you have them do the exercise faster. So instead of, just going at a regular pace, stand up, sit down, now try to stand up quickly and sit down slowly. So here's some example strength exercises for you. So On the left-hand side, we have an example of them working against external resistance. So this is a seated row with a TheraBand, or using body weight, like on the right. So the person is standing out of a chair, and in this example, she's using one hand, but you could always start with two hands, and once two hands is easy, then you go to one hand. Once one hand is easy, then no hands, then you go to a squat. There's always ways to make it more challenging. And then on the far right, we have a counter push-up, but an easier version of this one would be just going against a wall and doing a wall push-up. So this would work on upper body strength. All right, so now we'll talk about balance. So just a general definition of balance is it's the efficient transfer of body weight from one part of the body to another, or challenges to the specific aspects of the balance system, so like the vestibular system, or the visual system, and we'll talk about some examples. So on the left-hand side, we have an example of a static balance exercise. So this is where the person is reducing the base of support. So it's easier to stand with your feet together, and then the next progression would be to bring the foot to semi-tandem stance. So they're bringing their foot just kind of right beside the big toe of the other foot, and that reduces the base of support that they have to stand on. To make it even more challenging, you can bring the foot right in front, so the heel of one foot is at the toes of the other foot, so it's like you're standing on a line. That's even more challenging, so that's reducing the base of support even more. And then another way she could reduce the base of support is taking her hand off the support object. So taking her hand off the chair or the counter or the wall or whatever it is you're holding. And you can do that with lots of different static balance exercises. So standing tandem, one foot in front of the other, standing on one foot. Those are just some examples. And then another way you can challenge your balance is moving the center of gravity and control the body position while you're doing that. So here's an example of a seated balance exercise, shifting the weight from side to side. But you could also do this in standing, just shifting from one foot to the other. And you could also do it forward and backwards as well, instead of just side to side. And here's an example of dynamic balance exercises. And really where you want to go from your static balance exercises is progress to more dynamic, where the person is moving while they're doing the balance exercises. Because really that's more like real life, when you're walking down the hall and you have to avoid an obstacle. So that's one thing you could do, is obstacle courses. Or on the left, you could do like a dance routine or a dance class. On the right side, we have they're playing with balls, so tossing them back and forth forces people to kind of weight shift and react to events that are happening. In terms of aerobic exercise, these are exercises that noticeably increase heart rate and respiration without breathlessness or undue fatigue. So basically they should feel, you feel like your heart's going a little faster, you're breathing a little heavier. So examples of this, I have some in a minute, but things like walking, dancing, those types of things. The new step is also a good example of an aerobic exercise. So this is what I was talking about on a scale from 0 to 10, where 0 is sitting doing nothing and 10 is all out effort. That 5 to 6 range is the main target. If people are very vulnerable, they're just beginning to exercise, then they might need to start lower, so 1, 2, 3, 4 or so. Or if they're doing quite well, they're quite fit, maybe a 7 to 9 would be appropriate, but it may require closer monitoring. So some examples are things like walking, dancing, marching, and I say avoid seated marching where possible. So if people can stand, there's no reason that they should be sitting in the chair to march. Get them out of the chair and march on standing up. It has more carryover to functional activities, and I mean they can stand, so why bother sitting down unless you're really concerned about them losing their balance. But then you can work on some balance training and then get them into standing later. Another example is circuit training. So maybe have them do some strength exercises and then walk in between the exercises and then do some more strength training. So you could do a sit to stand exercise, do 5 minutes of walking or 10 minutes of walking, and then do another exercise after that. Okay, so again, enough of me talking. So I want to hear from you. What challenges do you have helping residents to exercise? So, what makes it difficult for you to engage residents in exercise? Or if you are a resident, what challenges do you have in exercising?
All right, and everyone, just take a few seconds to think of your response and type it into the questions box on the right-hand side of your screen. All right, so we're hearing from people that staffing levels or working short can be an issue with helping people to exercise. People's agility, or maybe people who are maybe more stiff or have arthritis and things like that can be a bit of a challenge. And do you have any recommendations for that, Caitlin?
Yes, so we're going to talk about some of those next. Okay, so I just wanted to give some ideas because as I talked about at the beginning of the presentation, residents in long-term care often have lots of things going on. So they could have physical impairments, like they've had a stroke or Parkinson's disease, or they have multiple sclerosis. And so that can have an impact on their ability to participate in exercise. For example, if they have a hemiparetic arm or a hemiparetic leg where they can't move it, or Parkinson's disease where they might have freezing gait, so they can't, they can't initiate their step, or they get kind of stuck, or multiple sclerosis where they have, profound weakness. So there are definitely modifications that can be made to accommodate these residents and should be made to accommodate these physical impairments. So here's just a couple examples. So if they have hemiplegia, so maybe they can't use one arm at all, you can do resistance exercise on the side, the functioning side, and then on the other side, you can do something like active assisted range of motion. So where you are helping them move through the range of motion, or if they can do it themselves, you can have them, do the whole exercise themselves. But if they can't, you help them move through the range of motion on that hemiparetic side. But definitely on the other side, they can still do those challenging progressive strength exercises. Or if they have Parkinson's disease and they have freezing gait, so let's say they get stuck and they can't initiate that step, it might be hard to participate in something like a dance activity, or where you're trying to go around obstacles or step over something. So what can help is visual or rhythmic cues. So a lot of times having something like music on, or singing a song, or clapping or tapping can help that step initiate, or a visual cue like having people step over. All right. Or if they have difficulty with wide or narrow stepping. So maybe you're trying to get people to do kind of like a V-step where you step apart and then step together. You could have them have to step over something and then step back in. Sometimes just having that visual cue helps them initiate steps. Okay, so I have a couple videos, so you're actually getting a sneak preview of these videos. They haven't been launched just yet. They'll be launched the week of March 5th on the website at the bottom there. Right now we have videos up for personal support workers, so there's definitely some tips in there that you could look at as well, but these ones are kind of aimed more towards group exercise. And this one focuses on some modifications you can make for physical impairments, especially if someone can't stand. So I know a lot of residents in long-term care are in a wheelchair, they're unable to stand and walk. So those recommendations I mentioned at the beginning were really targeted to those ones who can. And so these are some suggestions if they can't. So just to give you a heads up, the quality of the video might be a little bit choppy. It's just the software that we have, but you'll be able to see the full version without the choppiness in about a week and a half.
To keep residents strong and help prevent falls and fractures, residents should do exercises for strength and balance. Exercises done in standing are ideal because they encourage functional training. Functional training is working on tasks that residents do in their daily life, such as standing up and sitting down, getting in and out of bed, walking and dressing. Standing can also challenge a resident's balance and also puts less compression through the spine compared with sitting. Bending or twisting the spine while sitting can increase the risk of a spine fracture. But sometimes residents won't be able to do standing exercises. Some residents may be able to do certain exercises in standing, but not others. Or some residents may be able to stand on certain days, but not on others. It is important to figure out which exercises are safe to do in standing, or if it is a good day to try standing exercises. If the resident can't stand, strengthening exercises for the upper and lower body can still be done in sitting. For example, you could do seated knee extensions or hip abduction against a TheraBand. For the upper body, you can do upright rows with dumbbells or lat pull-downs with a TheraBand. Do 2 sets of 8 to 10 repetitions, with the last few being challenging. You can also do balance exercises in sitting, like weight shifting. Have the residents sit up tall and, keeping their back straight, lean from one side to the other. Use words like "be as tall as you can" or "grow taller" to encourage them to keep their backs as straight as possible. Make balance exercises fun and interactive. You could use a ball and gently toss from resident to resident, encouraging them to weight shift while catching and throwing. Or use music to do balance exercises disguised as dance moves. For more information, visit osteoporosis.ca.
All right. Okay, so one of the barriers that was mentioned in the last time I had the question, saying what makes it challenging to exercise with residents, is cognitive impairment. And as I mentioned, a lot of residents do have cognitive impairment for various reasons. It could be because of stroke, depression, traumatic injuries, medication, Parkinson's, Alzheimer's disease. There's lots of different reasons, and really it doesn't matter why. Ultimately, it doesn't really matter why, in terms of exercise, why they have cognitive impairment. But a common misconception is that residents with cognitive impairment can't benefit from exercise because they can't learn new skills and have difficulty following directions. But I'd like to challenge that. Evidence does suggest that exercise can improve functional mobility for residents with cognitive impairment. But it just might require a different approach because, difficulty following multi-step directions, responsive behaviors, or expressions, or increased distractibility. So it might be difficult to engage residents who have cognitive impairment. So what we did is we took some suggestions from the Alzheimer's Society of Ontario, and we kind of transitioned them and gave examples of what this might look like in the exercise world. So the first suggestion is to approach the person from the front. So when you're greeting them, stand in front of them, and then identify yourself. So before starting the exercise, introduce yourself and say why you're there. Hello, I'm Caitlin, and I'm here to do some exercises with you. Maintaining eye contact throughout your interaction. So, when describing the exercise and giving them feedback, keep looking at them. And also address them by name. So use their name when describing the exercise. So, Bob, I want you to stand up out of that chair. Next, you could repeat or rephrase their responses just to clarify what they're trying to tell you. So maybe they say, oh, that exercise made my legs feel wobbly. And you could say, oh, did that exercise give your legs a workout? Just to make sure that's what they mean and not actually like, I'm going to fall or something. Ask yes or no questions and allow time for a response. So instead of an open-ended question like, Jim, are you feeling okay? Where, it might be hard to formulate a response. Instead, Jim, and say that instead of Jim, how do you feel? Also using gestures to back up your words. So demonstrating it as well as describing it. Listening actively and acknowledging their emotional state. So a lot of times residents, when you go and say, hey, I'm here to do exercises with you, say, I don't want to exercise, I'm too tired to come back right now, or I'm too tired right now. You could say, I understand you're tired right now, but may I come back later? So you're acknowledging it and coming up with a solution. Also, let the resident know if you're going to touch them so that you can prevent startling. So listen, let them know that you're going to give them hands-on feedback. So, you know, if you're doing an exercise and you're going to touch their arm, tell them, Irene, I'm going to move your arm to the side so that they know if you're going to touch them. All right, so I have another video for you here. Again, this is a sneak preview. This one will also be available on the website, listed below on March 5th. And this one just gives some concrete examples of modifications for cognitive impairments and really summarizes what I just described.
Residents in long-term care might have cognitive impairments, making it hard to follow directions and participate in group exercise classes, but they can still participate. Here are some tips for working with residents with cognitive impairments in a group exercise class. When inviting them to class, approach the person from the front and identify yourself. Minimize distractions. Make sure the class is in a quiet room without other programs going on or people passing through. Address the resident by name. Use clear, simple instructions to describe the exercises. If you are going to give them feedback by touching them, let them know that you are going to touch them. This will help prevent startling them and causing agitation or fear. Give them small chunks of information in 1 to 2 steps. For example, instead of saying, put your hands on the rail and lift your leg out to the side and then lower it, break it up into small chunks. Place your hands on the rail, bring your leg to the side, bring your leg down. Demonstrate the exercises too, don't just describe it. Maintain eye contact to help them focus on what you are saying. Make exercises fun and functional. Use examples of everyday activities that residents will be familiar with, like standing up out of a chair, picking things up off the floor, and dancing. For more information, visit osteoporosis.ca.
All right, so to summarize kind of what we've been talking about for the last 45 minutes or so, exercise is part of a multifactorial strategy that can help maintain or improve mobility for residents in long-term care. Strength, balance, and aerobic exercises are the best ones, and they're going to help the most. And exercise should be done at least twice a week for 35 to 45 minutes, and that new study might even suggest more like an hour might be better. To make a difference, exercises must be challenging and they must be progressed. So they should always feel like they're working. And modifications can and should be made for physical and cognitive impairments. And I hope you got some concrete examples of how that can be done today. So my last question for you before we finish is, what did you learn today? So what's one thing you learned that you're going to change your practice? Or if you're a resident, what might you do different on a daily basis?
All right, and again, everybody, just use that questions box on the right-hand side of your screen to type in your response to this question. All right, and people are saying that they like the tips for exercises while sitting. They want to utilize more weight training with their nursing restorative program. That's fantastic. Trying to reduce sedentary lifestyle by, starting a program in the residence unit or home area, getting some more ideas for working with cognitively impaired residents would be helpful. Do you have any more tips on that, Caitlin?
Yeah, I think making things really functional and fun. A lot of people don't like the word exercise. So if you say, I'm going to do some exercise with you, let's do some exercises, that might kind of turn them off to actually doing them. But make it something functional, like we're going to practice standing out of this chair. It's exercise, but you're not calling it exercise. Or let's dance. If someone really likes dancing, getting them engaged in an activity that they like to do will be good. And it can be a balance exercise and it can be an aerobic exercise at the same time. So just trying to be, sneaky, I guess is the word, just trying to, or maybe creative is better, to make it fun and functional so that it's something enjoyable, but they're still getting something out of it. And especially if they have more advanced cognitive impairment, keeping it functional, so something that they would have done every day. So, like picking something up off the floor. It's kind of, you do it so many times throughout your life that it's just there. It's in the background. It's not like you're teaching them a new exercise that is they have to remember. It's something that they've already done.
All right, thanks for that tip. People are saying that they like that they like, not using the term exercise, getting creative with it. Some people are saying that they really love the pool noodle idea and some ideas about how to increase the length of the exercise or activities that they're doing with residents, and that some of them have already gone to the GERAS website to check out the videos, and they're finding that the PSW ones on there look like they're neat. Great. Yeah, and last but not least, does anybody else have any final questions that you want to ask Caitlin before we wrap up in the next few minutes? Yeah, and someone's just asking which website is used for the PSW videos, and we're going to include the link to that website with the PDF of the webinar slides that we'll be sending to you by tomorrow morning, as it takes some time for the webinar recording to generate, and then we upload it to our website and then to the REA's website. Yeah, and sorry that one of you is having trouble downloading the PDF. That would be in the handouts box on the right hand side of your screen, but we will definitely send you the PDF file with the email, with the link to the recording, and as well as a webinar survey. And so we really value your feedback, and we thank you very much for taking the time to join us for this webinar today. We really want to know your thoughts about what you think about it, as well as any suggestions you have for future webinars, whether that's webinar topics or possible webinar presenters. So you can let us know that just by sending us an email or responding to the short survey that we're going to be sending you. And thanks again to Caitlin McArthur for sharing with us this very useful and interesting information. I know I learned a few things today. And special thanks to Holly Hebner from the REA for her fantastic webinar support. And I'm not seeing any more questions other than there's someone saying about more engagement for small group exercise for people living with dementia, perhaps with activity staff facilitating it?
Yeah, I think that's a great idea. A lot of times, it's challenging delivering something that I described, where it's very frequent, time-intensive program, it's going on for a long period of time. So the more staff that can be engaged in the delivery of exercise, I think the better. So, when you need more of a prescriptive, structured exercise program, maybe someone's new to exercise, but you want to challenge them, that's when a physiotherapist or kinesiologist is going to be ideal. But if you're running more of a group exercise program, for people who have been exercising for a while, then for sure, I think as many staff as you can engage, the better. And that's those videos, if you go to the GERAS website, the link will be set out. That's really what we wanted to promote, that everyone can be part of this journey, the residents' journey in exercise and mobility. So I think the more staff we can engage, the better.
All right, and then one last question for you. Someone's wondering, is there a CPS score that you recommend for residents with cognitive issues that would make them suitable for participating in group exercise?
That is a very good question. I don't have a good answer for you as to, a 3 or a 4 or a 5 on CPS. I think it really depends on the resident, and we don't really have enough evidence to support a certain cutoff score yet. I think, you try to engage people as much as you can, but if group exercise is becoming an issue in terms of the residents really distracted, maybe they're interrupting the group, or it's making it challenging for other people to engage in the exercise, or they're just not benefiting at all because they can't participate, then it may be time to shift them to more of an individual program. But as of right now, I don't really have a recommendation for a cutoff score.
Okay, all right. Thanks for letting us know. And thanks for all of your questions and responses, everybody. Sorry that we couldn't get to them all. But like I said, feel free to either get in touch with myself or with Caitlin anytime. We're more than happy to answer your questions. And we're going to be ending the webinar now, and I hope you enjoy the rest of your day.